So I was presenting an abstract describing a population of children from the inner city who have had prior ICU admissions, so intensive care admissions for asthma. We're looking at a study of kids in general with an inner city asthma intervention where we're providing home and education, also looking at their environment, and we did testing for allergies. This study in particular is targeting children that are basically Medicaid insured. They come into where they're being recruited from an emergency department in the urban, basically in Baltimore City. So basically 96% of them are Medicaid insured. Our population is about 90% African American. And when we looked at the group that were previously in an intensive care unit versus not, there wasn't any difference in African American race, age of the patient, whether or not they're Medicaid insured, but of course that's our whole population. So we're trying to look at this population, and when we looked at it, we realized about 30% of the children had been in the intensive care unit. So we said, what is different about that group? We were, first of all, very surprised, because that group is really at risk to have a potential life-threatening or life-ending exacerbation. So that's obviously very concerning. So we looked at the kids that had not been in the ICU versus the ones that were, and we found that they were more likely to have used a lot of the rescue inhaler medications, short-acting beta agonists like albuterol. So they used that a lot more than the non-ICU group. And also they used a lot of oral corticosteroids for lots of exacerbations. So a very sick population. They also were more likely to be sensitized to ragweed, which is a fall allergen in our area in Baltimore. And we know that kids in our area are more likely to be in the ER in the hospital during the fall anyway. The other thing we found is that only about 13% of them were filling their asthma prescriptions at least half the time, which is pretty bad. So very poor adherence. The other thing is that only about a third of them had ever seen a specialist, and pretty much anybody in intensive care unit should see a specialist to prevent, obviously, the likelihood of having more severe exacerbations again. In Baltimore, particularly for children, and actually in the state of Maryland, and we see an underserved population. So fortunately, a majority of the children are insured through Medicaid. So it becomes less of an issue. Now what does happen, because we also have a mobile asthma care clinic that we run, is that they have to fill out paperwork to have their insurance, and sometimes there will be lapses. But in general, the fortunate thing is that they do have insurance. It used to be that you had to get a referral for a lot of those insurances, so that can be a barrier. But if they're in the hospital, they should be able to get at least a consult in the hospital setting to get things started. With our mobile asthma care clinic, the Breathmobile, we know that that's one of the issues. So trying to get off of work and the kids getting out of school, so that's why we have, I'm sorry a little, but that's why we have the Breathmobile, so it can go right to the kids in the neighborhood. So it definitely is an issue for parents to get off of work and the kids missing school. So, but it's obviously a very important thing, but people have competing priorities, and I think that's one of the issues. Well, I think a lot of it is education. So educating the parents and families that, listen, if you take this and have this appointment, the idea is to prevent these exacerbations, because if we don't get that asthma under control, convincing them this is a serious disease, and if we get it controlled, then the child's less likely to miss school, and the mom or dad are less likely to miss work. So, and not waking up at night, because they can't sleep because of asthma. So it's just a lot of education and reinforcement of important to keep your appointments, important to take your controller medications, but it takes a lot of education and working with the families and acknowledging that there are a lot of competing priorities, but also try and modify their asthma medication regimen so that you're working with that family to have buy-in where they're part of that plan. Very important. One of the things, particularly at my hospital where we have our mobile clinic, which is basically a free clinic, we're looking into ways where, since that's providing preventive care, can we tap in and some of the funding that's used for that to fund this particular program, because it's doing a lot. We show great outcome improvements in asthma. So it's a great program. It fits the priorities of preventive care, particularly for severe chronic illnesses that affect a lot of kids, and asthma is the main one.